So, good afternoon, dear friends and colleagues. Welcome to this session that is entitled A Mindset Shift in the Cath Lab, Leveraging Contemporary Technologies for Planning and Guidance PCI in Complex Patients. And it's a session that has been put together by Philips, and my name is Javier Escanet. I have the pleasure of being with Natalia Pinilla as spokespersons, and we have a fantastic lineup of faculty. We have Darius Dudek with us, Victor Kochka, Roberto Garbo, Nieves Gonzalo, and also we will have them in a minute with us, Mark Winkens and Alejandro Travieso. So I think I put together some.
So I think maybe while Javier put his slides on, we'll appreciate if you put the QR code for the question. So you display the QR code somewhere. I think that will be good for the attendees. We want to make this very interactive, so feel free to do any questions, and we will get the questions here in the screen, and we will go over. We can display maybe after your introduction, Javier.
Thank you, Natalia. So this is what we are going to be talking about. We are going to be talking about the place where we work. We are to be talking about the many tools that we have around us that in many cases we do underestimate the power they have in improving the quality of our PCI. We are trying to make a session where we will be generating an idea of how improvement in many different levels of the technology that we have in the cath lab can contribute to address the complexities that we find every day in our clinical practice. So the session objectives for this is to discover features that you might not yet know about the cath lab systems and learn how to integrate them to make your interventions easier and more effective. We would like also to together understand how intracoronary imaging, physiology, and angiography contribute to a better and more efficient planning and performance of complex PCI procedures, to understand how the seamless use of in-cath lab systems can enhance procedural workflow, safety, and quality, and finally, to get a first clinical experience on a next-generation image processing technology in interventional cardiology. And as I mentioned, we have this outstanding group of colleagues that are going to be with us, but the most important, of course, is you. We count with your engagement because your questions and insight will be key in achieving these objectives. And with that, I will think, if you want, Natalia, to present the first speaker.
Yes, so we have our first speaker, Darius Dudek, to talk about why thorough planning and guidance of complex PCI procedures is more important than ever.
Thank you very much for this interesting symposium. So I would say that for the last 25 years doing PCI and for 15, 20 years we are saying that ultrasound is important and imaging is important for the optimal outcome of PCI, but now I would say that we have the new opportunity because we can reduce the contrast dose and radiation with the advanced imaging. I would say that nowadays the PCI are really complex. We have more patients which are aging and more complex procedure, so we should take a lot of difficulties with the calcified vessels, complex lesion, and also the same patients have the problem very often with the renal failure. Even with the current data, the newest generation stands, if you look for the complex procedure, all the time outcome is worse than for the easier procedure. So all the time we should have the good planning and strategy to achieve the better results. There are a lot of tools in the current interventional cardiology which are useful to optimize the results. Today we'll be discussing on physiology and imaging, and this is important for outcome. During a session yesterday and today, there was a lot of discussion that the imaging could be and functional assessment important, but I would like to remind you that since 2024, it is 1A indication. We have to use the FFR, IFR for selecting lesions for treatment. QFR is also mentioned in guidelines, but we know that there are some discussion and difficulties with the full interpretation and implementation of this technique. So I would say that the invasive measurements of physiology is critically important and recognized by ESC as the 1A indication. Same for the intracoronary imaging, that we want to remember that in 2023, with acute coronary syndrome, it was recommended on left that for the guiding of PCI culprit lesion, 2A indication for ultrasound, and even for recognition of the non-clear culprit lesion, we can use the OCT or ultrasound to recognize patients which are subject to treat, and was 2B indication. In 2024, for chronic coronary syndrome, intracoronary ultrasound or OCT is recommended again with the class 1A. For complex lesion, particularly left main, many operators still don't do left main without ultrasound, which is doubtful because this should be specially checked, and also through bifurcation and the complex long lesion multivessel disease. Of course, if you want to check your results after PCI, the IFR, FFR also could be used for your class 1A indication according to guidelines. So nowadays we are very focused on the pre-procedural planning, like we were educated for structural heart intervention. I think it's time coming for chronic coronary syndrome that you need a good preparation before going to procedures like we do for TAVI with the CT. So here our tool is ultrasound. We can easily measure the vessel and lumen size. We can do easy co-registration in good equipped cath labs, angio, ultrasound, and physiology. We can eliminate geographic miss, looking for the plaque burden and the healthy to healthy stenting. We can confirm stent dissection at the edges of the stent. And of course, we use everyday practice, we do the stent apposition and expansion by ultrasound. The question to use the ultrasound OCT, I would say that based on the recent data, is not so important. I would say that the conclusion from this real-time network meta-analysis was that intravascular imaging guidance for PCI is certainly better. So I would say that if you use the image-guided PCI, it's much better than angio standard PCI, and I think that all operators agree, and it's strongly recommended by guidelines and scientific data. So nowadays also we have, as I said, many patients which are elderly, a lot of calcified vessels. We have a lot of tools like IVL, we have the rotational atherectomy, lasers, balloons, high pressure balloons, non-compliant balloons. And with the imaging, it's much easier to decide and to select which tool is appropriate for your PCI with planning of your strategy. After the stenting, we can assess in ultrasound, OCT, or the stent boost the enhancement techniques by good quality angiographs to see if your stent expansion is good, and this is also important and helpful according to many recommendations. So that's why if you have the cath lab, which is equipped with ultrasound, with physiology, with dynamic coronary roadmap, and you can do the co-registration, certainly workflow is better. You can probably reduce the radiation dose and contrast dose using very fluently those techniques. So nowadays, I would say for our planning of the PCI, we should use in some chronic cases CTCA, so cardiac CT. We should use ultrasound, physiology, and advanced technique with angiography like DCR, because everything is important for planning our procedures, for checking the quality of our procedure. In case of failure, we can diagnose the problem. So with CCTA also is important, not only intracoronary, but also the non-invasive assessment, because even in recent consensus by EuroPCR and European colleagues, and here we see the SKY recommendation that difficult lesions like severe coronary calcification, bifurcation lesion, diffuse coronary artery disease, aorto-osteal lesions after bypass, CTO, and prior bypass surgery patients are well defined by CCTA. So this is another tool with imaging. We can prepare our patients, and this is the example for this consensus. On the left, simple lesion, and you can ask the center which is not so advanced and the PCI operator. But if you see the picture on the right, you certainly need a complex operator and complex PCI center to deal. So I think that this area is also coming with pre-procedural planning from chronic coronary artery disease using CTA. And finally, I would say that nowadays, even in the recent data, when you do the complex anatomy like this recent publication, all the time the complex anatomy increases the risk of acute kidney injury, even in recent data. So that's why we should remember about the concept of the ultra-low contrast PCI. basically we say that we should use the amount of contrast which is no bigger than 1:1 ratio to GFR. So if your GFR is 30, you should use 30 milliliters of contrast or less. And with the advanced imaging and physiology, you can achieve this. So in conclusion, I would say that the lack of dependence on contrast administration and more common use of physiology, new generation imaging may allow for the more complex revascularization with higher proportion of cases and higher quality interventions. There is no doubt, and we have the 1A clear recommendation. And access to ultra-low contrast PCI facilities correct diagnosis and treatment of coronary artery disease while minimizing the risk of renal deterioration, so you can use just lower amount of contrast using advanced imaging. Thank you very much.
Thank you very much, Darius. That was a perfect way of putting a frame to what we are going to be discussing. Again, this edition of EuroPCR is dedicated to patient complexity. Nieves is something that we see more and more. And probably, you know, Darius highlighted, for example, that the patients that we treat, they are survivors to disease. Many of them, they have cancer. Many of them, they have chronic kidney disease, etc. Can you elaborate a bit also on the value that these techniques, for example, of ultra-low contrast PCI, may have not only in improving the safety of decreasing acute kidney injury, but perhaps also allowing more complete revascularization? Could you like to elaborate on this?
Yes, thank you, Javier. So, yeah, actually, you mentioned complexity is the central topic of EuroPCR this year because, as I said in the opening, this is a global problem we all face. We have more and more complex patients, complex lesions, sometimes also complex environments. So, and actually talking about the environment we work in is very important. And the close environment is the cath lab. So really having the opportunity to have cath labs that can help us integrate these tools really facilitates treatment of these patients. And as you were mentioning, use of ultra-low contrast technique in general does not only allow treating patients with kidney injury. It's not only for this type of patients. It allows you to treat patients with multivessel disease maybe in a more complete way, also to perform complex interventions with an optimization that in the past, we all knew that sometimes in these high-risk patients, the idea was like go as fast as possible, in and out as fast as possible, leave the patient, just make sure the patient is alive when he leaves the cath lab, but maybe not paying so much attention to optimization. So definitely I think we have changed. If you're going to perform an intervention in these patients, you need to make sure that it's properly optimized, and using all these tools that allow you to do it with less radiation, less contrast, of course, can help you treat these patients in a safely way, but also in a much more optimized way. Yeah.
So, Natalia, let's ask the colleagues one question. Let's ask the colleague, when they hear about ultra-low contrast PCI, let's see how many of them think about patients that have chronic kidney disease. So let's put the question. We say ultra-low contrast PCI. Who do you think that the first thought that comes to your mind is patients with chronic kidney disease? Can you raise your hands? Okay, very good. And if we say ultra-low contrast PCI, who of you immediately think this is important also in many other patients apart of patients with chronic kidney disease? Okay, well, it will be balanced. Roberto, you're a CT operator. And CT operators, I think that by definition are ultra-low contrast PCI guys, don't you? I mean, can you elaborate on that?
Yeah, I think that this is a great concept. It's a concept of modern approach to PCI. So now we have more and more complex lesion to treat, complex patient, as Nieves has explained really carefully. And we know that paradoxically we can achieve the best result, even the most complex CTO, using less and less contrast, using more imaging, using modern technique like in CTO retrograde approach, and then IVUS. So we need to understand that contrast is not useful, can be a danger when you have a dissection, when you are doing reverse car, subintimal space, subintimal tract. So we know that in this case we need to avoid contrast, and this is something that we can apply to all complex PCI. So we have a great advantage. We need to take advantage of this new tool we have in the lab. And this is something that we need to achieve to to have an optimal approach to the modern PCI.
Yeah, that was a great point, Roberto. And I think I will say in this panel, most people perform complex PCI. And when we tell the attendees, okay, now you have to assess a cardiac CT, then you have to do physiology, imaging, you have to do ultra contrast PCI. I think what is the sense, planning all of these, how much that transfers in our procedure itself. So I think, Victor, you do a lot of complex PCI. We want to ask you, how do you feel planning your procedure this well interferes in your radiation exposure, procedure exposure, like those things that we are actually worried about ourselves in the cath lab? How do you think it transfers into it?
I think it's a complete change of a kind of a mindset. You know, we used to be the interventional cowboys coming in at 1 a.m. and treating the simplest TEMI. Now we are kind of thoughtful persons, you know, females, males, coming into the lab with all the knowledge, using all the technology available, sometimes stopping after the diagnostic procedure and not doing ad hoc PCI, re-evaluating, maybe selecting the best operator for the specific case, and then doing this in a planned fashion. So I think there is a mind shift from more of the acute stuff, which still is being performed, to a more kind of thoughtful, slow, more intelligent approach to the things.
Fantastic. So please remember, you have microphones over there. We are warming up, of course, but I think that the best way to warm up a bit more is to have Nieves sharing with us how this happens in reality. So Nieves has recorded a case specifically to share with you at Hospital Clínico San Carlos, and I'm sure that this will be the best way to move on. Thank you, Nieves.
I think if we ask, can you guys please display like a QR code for the questions? I think we haven't done that. Is here? Okay, so perfect. So you feel free. I haven't had any question, and we are like 10 minutes in the session. So feel free to throw any questions. We will make sure we go through those ones.
Okay, so thank you, Javier and Natalia. I'm going to show you how do we integrate of all these tools in our practice through basically a case. So this is just repeating what we have been mentioning, the increasing complexity, patients that are older, more calcium, more CKD, multivessel disease, complex lesions. And we are obliged nowadays, really, if we want to achieve a good result, to use physiology, IVUS, and try to reduce contrast and radiation dose in our procedures. And of course, these are a lot of things that we need to integrate to make sure that they don't affect the workflow in the cath lab. And for that, the integration is essential. And actually, this is what we can see in in a Philips cath lab. So everything is integrated. You can see here physiology, co-registration, DCR, IVUS, sync vision. Everything is integrated. Everything can be used from the table. The operators can manage all these tools, and I think this is really the key to make it useful for the operators and to make it, useful for the patient, which is the most relevant part. So, as I said, I'm going to show you how do we integrate all these tools in our clinical practice through a case. This is a patient of 82 years old, anticoagulated with some degree of chronic kidney disease. He came to the cath lab with effort angina, and as you saw in the image, in the cranial view, he has a lesion in the mid-LAD with calcification. He also had some degree of ostial stenosis in the LAD. So we thought that we needed some physiology to understand the relevance of this ostial lesion. He also had calcium, as I mentioned, so of course he's a patient where we would like to use IVUS to optimize, and he's a patient with CKD, so also we need to reduce the use of contrast to avoid potential further kidney injury. So how do we do that? I'm going to show you the case. I've edited it to 3 minutes, so you can see all the tools integrated. First, we're going to start with this injection with the new angiography systems from Philips. You see there the old name, but the new name is Smart IQ. This is a system that really allows you to acquire excellent angiographic images with a low radiation dose and also low contrast use. Here you can see I'm using the dynamic coronary roadmap to navigate the wire, and immediately we are assessing the significance of the lesions with an IFR pullback. You can see here how the pressure wire is being pulled back, and immediately you will get also an idea of the co-registration with angiography that will, of course, in these situations help us a lot to understand where is the problem. And in this case, you can see that really there is some degree of diffuse disease in the proximal part, but there is an area in the mid-LAD that can be treated, and with that we could normalize the functional value in the LAD. So treating this mid-LAD lesion could be enough to really solve the major problem of the patient in the LAD. Next part, of course, is understanding the morphology of the lesion, and for that we are advancing here the IVUS catheter. You will see now the pullback with IVUS, and this, of course, gives you information about the size of the vessel and also the morphology of the plaque. You can see that there is calcium, especially in the proximal part, with this more circular shape. Again, co-registration with angiography and IVUS facilitates a lot interpretation and facilitates locating the landing zones and also understanding the length of the stent you will need to treat this lesion. Based on the morphology of the calcium, we decided to treat this lesion with cutting. You can see we are using a guiding extension. And after that, you can see we are here assessing with IVUS the presence of fractures. And as you can see, I'm doing that from the table. I'm using the table on the tablet that you have on the table, and I'm just making all the measurements in IVUS. After that, we are implanting 2 stents with the measurements we had. We're using stent boost and DCR to locate them. And we see that there is some distal under expansion and also proximal malapposition. We are fixing that, post-dilating both segments. And this is the final IVUS post-optimization, where you can see that we have achieved a good result with an adequate expansion and apposition. And this is also the final functional result. In this case, with FFR, you can see the final FFR is 0.89, so a normal functional result after the intervention in the mid-LAD. And I wanted to show you this last injection. You can see it doing hand injection is a diluted contrast injection. So you can see that really with this new Smart IQ system, you can acquire these angiograms with diluted contrast and with an excellent quality. So again, it's a new tool that we are adding to the palette we also already have for ultra-low contrast PCI. So my message is that really this seamless integration of new angio systems, physiology, roadmap, IVUS, stent boost, really this increase the quality of their vascularization and can ensure patient safety in this environment, as I mentioned, of increasing complexity we all live on. So thank you for your attention.
Thank you very much, Nieves. I mean, it's real life, and it's what we do every day, by the way. I mean, this was not done for a recording. This is what we do every day. And it has to be like that, because if we are also busy in our cath labs, we want to deliver the best possible care to our patients, but it's true that by not having to put together different pieces of a system, having everything integrated, everything runs very nice. Natalia, I think that probably what the colleagues are interested is this protocol of imaging. Obviously, if you are able to get this quality of image with 50% contrast, again, it's something that might help in patients where you want to reduce the amount of contrast. Victor, you have experience on this system, so perhaps you can walk through the colleagues exactly on the principles, or perhaps even show some comparison of the images.
Can you hear me? Yeah. And in fact, I think if you... I just borrowed Nieves, congratulations on the great case. I just borrowed the last image and projected it now. That's the last image which Nieves did. And I think if she didn't tell us that it's a 50% diluted contrast, I would probably not have noticed. That's because of the Smart IQ, because this is the same dose as the Clarity Low, so it's not at the cost of any increased radiation, but this is amazing. This is really, really amazing stuff. And we have the luxury of using the same software in Tilburg, and Mark has provided me some images. This is the argument 1, which is using the new software post-processing to reduce radiation. So this is a acquisition of the same projection, same position of the gantry, everything is the same, but that's the Clarity IQ, and that's the Smart IQ ultra low. So this is low, this is ultra low, this is about 50% of your radiation dose. So it's not 5% or 3%, but it's 50% low. It's a dramatic reduction. This could have consequences. This will definitely make the room safer for our patients, but also safer for our staff. And there's a lot of young people, young interventional cardiologists, males, females, nurses, who will benefit greatly from having less radiation. Also, I think in the future, it might enable us to work lead-free, which I think would do a lot of good to my knees. Then you can also look at this image, which is coming from my center, and that's the argument number 2, that if you have a difficult to image patients and for some reason you want to go into a more oblique projection, this patient has a BMI of 45. And the left image is the Clarity IQ low, and the right image is the Smart IQ low. So the same dose of radiation, but I think you can see for yourself that the image quality is a lot better. So you could use this for obese patients, you could use it for patients with borderline lesions, which you want to see better. I think that's the image speaks for itself. And then we have the third image, and I think that's up to the topic of the ultra-low contrast. We need to do IVUSs, we need to do all these things, but we can also do something simple. So just using the Smart IQ technology and injecting less contrast will still keep the same image quality. The image on the left is the Clarity IQ, the image on the right is the Smart IQ, both on the medium setting, but it's 50% contrast. So I think that's my summary. It's the new software gives us a lot of options. We have a lot of options. We can play with the buttons at the bedside, at the console. We can increase the radiation and save contrast. We can keep the radiation the same and have better image quality, or we can we have all the options available to us. Thanks.
Yeah, lovely presentation. And, it's great because you illustrated 3 different scenarios, so frequent, and particularly the patient with the high body mass index, which sometimes impairs so much the quality of image, and at the same time you increase so much the radiation to the patient and to the team. Natalia, do we have any questions from the comic?
We do have some interesting questions. I think I can ask Victor first for your experience. Is this new tool, is it a trade-off between the radiation dose and contrast dose? Like, what is the balance using these?
Yeah, there is always a balance. I think every patient is different, so we need to individualize. So someone who is young and is 45 years old, or maybe pregnant lady, there might be other reasons to try to absolutely minimize the radiation and accept kind of average or acceptable image quality. There might be other patients who are 85 years old and have borderline kidney function. I hate the patient with borderline kidney function. If the patient is already in dialysis, I can't do much harm. But I hate the patients with creatinine 200, 250, 300, still having decent quality of life, not going to dialysis every 3 times a week. And then if you give 50 cc's of contrast, that might be the kind of cutting edge between ending up on dialysis or not. So I think we can individualize.
I think that if we can see more, so it's better to take the ultrasound, and if you have doubts with your stenting, then to push and puff the contrast.
So one more question here, Javier, and I think this is for Nieves, because Javier, you were doing the comment that in your cath lab, this case is not a special case that you're recording. This is your workflow in your cath lab. So I think for Nieves, some of the comments are like, these are too many techniques to be used in the same case. So what do you recommend like for the learning curve of people? Are they to be trained in this workflow in a super calcified left to stent bifurcation? Or what do you suggest to them like to get training to integrate in all of these techniques?
Yeah, thank you, Natalia. I think that's a great question. Of course, if you if you want to start using these technologies, you shouldn't start with a super complex case. On the other hand, it's important to understand that you should treat every case as an important case and as a case that you need to optimize. Once a patient has serial disease, once a patient has calcium, is a patient where, in general, we believe that both physiology and IVUS have demonstrated that they are useful, and that was the case. I mean, so really, as Javier said, it's not an exceptional case. It's a case that we were doing one day. We thought it was a good example, maybe to demonstrate how these tools integrated in the lab manage, as you saw by the operators. We don't have any technician that needs to measure up for us the IVUS or needs to do some measurements with physiology. We're doing everything from the table. Actually, I was doing this case with one fellow. The other person you see there is one of our fellows that is in training. We are doing the case together, and we're managing all these tools from the table. So I fully agree. You should start maybe not with the most complex case. There are sometimes also the most difficult to interpret, etc. But remember, I would say that I will try to give the same importance to every case, not only to the super complex left main that we are very interested, but approximately this is also important for the person you're treating. You should always try to optimize that.
Yeah. Natalia, if I can make a comment on your great question, I think that is the same concept of imaging IVUS in CTO. So you have the most complex situation, and you need to understand that imaging can help you a lot in that complex case if you know, if you understand the imaging, what you are going to see, and what IVUS can help you in that situation. So you need to start from simple case. You need to understand which is how is the plaque, how is the subintimal space, how is the calcified lesion, and then you can go on, and then you will use more and more IVUS, because the comment of Javier is essential. So they use it every day, these tools, but we will have a real change in the mindset if we will have globally the use of imaging should be more than 50% of PCI. If you stay below 10%, we will talk, but then in the end, if we don't have education, we will never grow up of the level, and the guidelines are not enough to increase this level to reach really the optimal PCI.
And let me add something to what Roberto has said that is very important and is one of the objectives of your session. In your cath lab, in your systems, I'm positive that you have features that are extremely useful for the management of complexity that are not used every day. And they are still lying there. I visit sometimes hospitals where they have dynamic coronary road mapping, which is an amazing tool to navigate wires, devices without using contrast. And people sometimes are not using it. And we have to understand that we have this type of mental inertia that together we have to break, we have to overcome, to really make sure that the whole team understand that these are important features that took a lot of energy to the engineers from the companies to develop, to bring a benefit to the patients.
And then, Javier, if you remember, actually, I've seen for the first time in your lab in April the new X-Res 5 technology. Exactly, and I use in the complex retrograde, but was amazing. So the imaging is incredible. So and we were able to do a live case with new system retrograde, but was really easy because we were with Pablo together in the lab, and this was really good. So I think that we need to take advantage of this new tool we have in the lab to have better PCI for the patient, and either to reduce X-ray for us and to reduce contrast.
And we should add that it looks like as a complex, but it's very easy. When you use in everyday practice, this workflow is very easy. So at the beginning, you think there's a longer procedure, but when you are experienced, after a short learning curve, so it's easier, faster, and with more precise PCI.
I think that we have the opportunity to have two more glimpses into the practice. The first one will be provided, I believe, by Mark Winkens. You're the first one, or Alejandro? I don't remember. Yeah, Alejandro? So Alejandro will give us a glimpse, and then Mark Winkens, Alejandro Travieso. He works also in Hospital Clínico San Carlos, and he's going to show us an example of using the technology you have in complex cases.
Yeah, so hello everybody. As Javier said, this is a brief depiction of what we do every day and how can we use all tools to treat our patients. So this is a 70-year-old lady with known allergy to contrast media. She had chest pain for 6 months with a positive stress echo showing hypokinesis on the anterior wall. And then a coronary angiogram with pre-treatment for the allergy was scheduled, and that's what we have. This is the coronary angiography. You can see here tight lesion on the mid-LAD with some calcium, other lesion in this abnormally with LCX with abnormal origin from the right sinus, and no significant disease on the right. But during this procedure, she had anaphylactic reaction, even though she was pre-treated with corticosteroids and antihistamine drugs. So we had to stop here. We just had the time to do some IFR to the LAD that showed a positive result. So then we stopped. We could not do anything else in this procedure. We consulted again to the allergy service. We changed the medication, and then we planned our procedure aiming for complete revascularization for both LAD and the circumflex. So we started with the LAD. We engaged the left main. We put 2 wires, one as a landmark in the a diagonal branch, and then we started with predilatation. We can see here some calcium indentation in the LAD lesion, and then we tried to pass our IVUS catheter, but it didn't cross. So we switched our plan, we escalated to IVL, and we delivered 120 pulses, and you can see here how we started and how we ended.
So Alejandro, let me ask you something. I understand that the case that you are showing is that all this is performed without giving contrast. Is that correct? You premedicated the patient just in case, but the intention was, if possible, not to give any contrast. Is that correct?
Yes, so our aim was to give us the lesser contrast possible. So we have the contrast prepared. We don't have to be dogmatic about that. But our aim was to do it without contrast. But of course, sometimes the plan changes. And so far, we haven't used a single shot here, even though we have gone for advanced calcium modification techniques. So then we managed to cross our IVUS catheter, and that's what we can see here, the calcified lesion in the mid-LAD, and we selected our landing zones, and we have information enough to place our stent. So of course, this is a long stent. It's a 30 by 30 millimeters drug-eluting stent, because we haven't used any contrast. We have to be sure that we cover the whole lesion. And we also have our landmark of the wire in the diagonal branch. And then we repeated our IVUS. We can see here no edge dissection, either proximal or distally, and some fairly good expansion, and although it can be optimized a bit, and so we went for that. We post-dilated our distal segment with a 3.0 NC balloon, or the proximal segment with a 3.5 NC balloon. And that's it. We perform a TT echo on the table, no effusion, no ECG changes, no chest pain. So our procedure was done here. So at the end of this first procedure, we use 0 milliliters of contrast. So then we schedule another procedure, again with pre-medication, with the contrast ready to be used. For the left circumflex. And you can see here briefly how we proceeded. We started blindly using our previous reference. We put the first wire in the branch. We put our second wire in our target vessel in order to create the skeleton that will be the reference for us. And then we started pre-dilating the lesion. And then we cross our IVUS catheter. We can see here the marks that are also useful for assessing visually the length of the lesion. We did our IVUS pullback, assessing the whole vessel up to the catheter. We co-registered the image that we had on the IVUS, and that's what we have. So this is the assessment of the lesion. It's not a huge vessel, not particularly calcified, and we have that's the information that we need.
This is a co-registration that instead of using the opacified lumen is using the
wire skeleton.
That's very nice.
So then we went for the stent. We measured roughly 60 millimeters, and again we selected a larger stent in order to be sure that we covered the whole lesion. We post-dilated with an NC balloon, and then again we crossed our IVUS catheter, and we did our pullback to assess the whole segment that you can see here. Also, no edge dissection, both proximally and distally. And as Javier said, we can always co-register even though we don't have contrast. And here you can see, even if the automatic track of the software is not correct, you can also manually edit it using your wire skeleton, tracking the vessel all the way down, as we did here. And that is something that you can also do it from the table. If you have somebody outside, it's always easier, but you can do it as a single operator as well. And that's how you have your co-registration. It's a very easy way to assess the whole vessel. And here you can see how you can correlate your IVUS pullback with the X-rays. We are assessing here distal edge. Stent expansion is pretty good all the way up, and no major complications. And also the expansion here, even though the vessel was not huge, is pretty good. You can see here we're tracking the area of our stent is 4.4, so pretty good for a circumflex. And that's something that we do regularly in our everyday practice. And you can see here also proximal edge of the stent, all good. And no geographical miss of the lesion. So we finalized again with the TTE. So we were sure no pericardial effusion, patient without chest pain, no ECG changes. So we were done. We removed our wires, and the procedure was completed. So this was us. I don't want you to look at us, but I just want you to look at this. So there are no excuses, even if you are basing your procedure on a previous angio. This is the previous angio that we printed and we pasted on our screen, and we didn't change projection. So this is very useful. It was at this point very useful. And again, zero contrast. See, this was at the end of the procedure. You can see here, this is Spanish, but you must believe.
To do with all we can have in our lab to have a better job for us, for our patient, to have a better result, even in complex lesion.
And I think that something that Natalia mentioned before is when somebody asks you, what about how can I manage that if I don't have IVUS, etc. I think probably the answer, the most important comment is saying what you should do is try to get it. And if you have problems in getting it, we can provide you help on doing that. But I think that the idea that you're actually seeing that these technologies are required to do things with a standard of quality, delivering to the patients, should not be, well, but I don't have this. There are ways of improving the adoptions. I mean, the administrators will be responding to you if you knock to the doors, you bring, the request of doing better medicine, don't you? So, Natalia, your take-home messages?
Yeah, we hope we introduce this concept of the mindset shift. However, our community is going through this for a long time. So I think we hope we achieve to share with you that there are several cathlab tools that can be integrated in your workflow, and this makes your procedures actually easier, faster, and safer, which is at the end the main purpose of our specialty. And contemporary PCI, I think about it when we talk about complex, because all you need to make a procedure complex is doing physiology, showing diffuse pullback, in the diffuse disease, doing imaging and see a calcific nodule or see involvement in a bifurcation. So I'm not convinced we do simple PCI all the time. I think most of our procedures are complex. And contemporary PCI means the integration of all of these tools, physiology, imaging, and it's not just angiography, are the tools that are attached to angiography to develop a systematic workflow. Like this is not to do in special cases, this is to use in all your cases, and that's how strong you're gonna become. And this allowed us to perform good PCI with good outcomes. And this is very important, we share this with you guys, a seamless use. In order to achieve a seamless use, you have to integrate this every day in your practice, because the more you do it, the easier it becomes and the more familiar you are with it. Thank you so much, everyone, for joining the session today. We hope to see you again.